So today's presentation is entitled Working Smarter, Not Harder. These are part one charting tips. And our two presenters are Dr. Sarah Smith and Tim Wayman. So as I alluded to previously, Sarah is a rural family physician, has many hats associated with that role, but she's speaking today about her Charting Champions program. So without further ado, Sarah, we'd love to hear from you.
Thanks, Lindsay. Welcome and morning, everybody. We're going to dive right in. And so you can use the chat box while I'm talking, as it's a good way to get a bit of interaction, and it might be a way that I can help you rather than just waiting till question time. As I go through some of these slides, if there's things that come up for you, answers or things that really get in the way of you getting home at the end of the day with the work done, then I want to hear from you in the chat box. Okay, so we know that the end of the day doesn't feel good if you've got a whole lot of incomplete charts and all the inbox work. So this morning's question is, how much of your charting is done and billed when you finish up with the last patient of the day? So what do you think? How much of that charting and billing is done? Okay. And the reason I ask that is that for many of us, we're not getting that charting done in real time. And that's okay. We're going to go through strategies on how we might do that. But we also might be having a story about our clinical day that isn't necessarily, I love my job, I love my patients, everything is wonderful and rosy. You may have had sentences like this or similar. I certainly was in that overwhelm about my clinical day, myself as a family doctor. So it looked like, what else do they expect of me? I can't fit any more in. Stop asking me to do things. This is the straw that broke the camel's back. So these were sentences that I would have about my clinical day. And it is not a nice way to go through our clinical day. Does it ever end? I'm never done. I could work 24/7 and still not be done. If you have these types of stories and sentences in your head, then I want you to know that there is a different way of doing this if you want it. All right, why are we talking about this? Well, if we take work home and we do it in the evenings or on the weekends, which was the advice I got from my preceptors when I said, how do you do this paperwork thing? They would say, come in on Saturday or come in on Sunday. If we're looking at doing that work in the evenings or on the weekends, then we're looking at a lot of hours. And so this is an opportunity to create time. We can't create time, but sometimes if we do things in a different way, we really can benefit. And this could look like an extra 6 to 8 hours a week if you're doing that sort of work in the evenings or weekends. So how do we do it? How do we get you done and home as fast as possible? So this is the pathway that I take physicians through when they are wanting something different. When they're wanting, for me, I wanted to be done after the last patient was done for the day. I wanted to close out that chart and know that the day was done and go home. This was a completely different experience to what I was experiencing before. And this is the way we start the process. Do you have to do it this way? Of course not. You're always the boss. But these are the steps. So foundational step is that completing your charting after every patient. Now, that may feel like a completely impossible goal right now, and that's right. But it's an interesting concept to let your brain think about, because you are an amazing problem solver. That's what you are as a family doctor. And as you start to be curious about how can I help me too, you can start to find answers within that problem-solving brain. Leading your clinical encounters, your exact plan for inbox work, and managing our interruptions. All right, so let's dive into problem number one, which is completing our charting after every patient. When I say that, what comes up for you? What are the immediate objections to that suggestion for you? And in the chat box, I'm looking at about 70 to 80% of your charts are done by end of day. That's just for a few of you here. Not all of you answered that question, but it's just interesting to note that, yeah, there's some work left over at the end of the day. So even when I have referrals to do, even when I have students today, even when I just came out of the room with a patient who clearly is mentally unwell and needs to go to the emergency department, and into the next room and I have a chest pain, into the next room I have another disaster happening. We get those days, okay? So how do we start to do this? So you are the boss with regards to what is in your notes and why. We know that we have college standards and medico-legal standards and what is required to be in the note. But what else are we putting in there? Are we padding it out with a lot of information that may or may not need to be there? And you're the one who has to evaluate what is in your notes. We talked yesterday about B- charting, and that means we do our A+ medicine, but our note is just a reflection of what happened. It is not a judgment on who you are as a physician. This is the informational continuity. So just being curious with how we're doing our notes is important because obviously that has a time impact. What is our brain telling us is more important than the note? And I like your comment there, Mary, that staying on time is difficult. And so if you're worried about, well, there's a patient waiting, or there's 3 patients waiting, or I'm an hour and a half behind, if we are in our day turning up and seeing that, oh, if I come out of the room to do my note, but then I rush to the next room because there's a patient waiting, that is just the way I have trained me to interact with my clinical day. I've told myself that that next person is more important than me getting this note done right now. How and where could you get that note done if you wanted to? So think about it. If you're in a pod where there's a whole lot of people walking past, I actually moved location in my office there for a week or so, and I was sitting in a different spot. And people would walk past and be like, oh, Dr. Smith, blah, 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 blah. Oh, Dr. Smith, blah, blah, blah. I'm like, wow. Well, no wonder I don't normally sit here. This is completely disruptive to me doing the work of the day. And so where would I do that work? If I had to stay in that location, I wouldn't be sitting there to do my noting between patients. It would either happen in the consult room, I go find a different office to do it in, I would literally do it anywhere else. And what stops you as you start to be curious about doing this? What gets in the way? If we think of it as an obstacle course of things that are going to get in the way of you achieving this, if you have a goal in mind that you would like to achieve about this, then we just think of obstacles like an obstacle course. All right, there's a patient waiting. Do I leave them in the room for a couple of minutes and get this note done? Or do I move into the next room? And as you notice how you solve for that, you will get closer and closer to that goal. Leading your clinical encounters. So running on time is difficult. Yes. And patients have an agenda. Yes. If we want to see patients and close charts, but what's getting in the way is, but I just talked about 10 different things in the room. Well, that now has a consequence of I have to now chart 10 things in the room. Or if we think about that referral letter, so we're seeing the patient, we're managing their diabetes, they bring up their knee, they want to be put on the list for a new knee, and we say, sure, I'll put you on the list. But we don't include that or think about that as part of the clinical encounter. Now we're giving ourselves homework. So this is making decisions with now and later in mind. Now, a referral to go on the knee list, not such a big deal. But if you've got someone with headaches and you need to kind of go through their chart and figure out what sort of pattern they've had, if they had any imaging about that, do I want a neurologist or do I want more imaging or that type of thing, then that's a bigger ask. So you're like, sure, I'll refer you to neurology, and away they go. They're not seeing you do that work. That work is part of the value of this consultation. They came saying, I want to go on the knee list. And they're not sure when that will happen. Their anxiety can be high as well. But if you're in the room saying, sure, let's get you on that list, and this becomes part of the encounter, it's They're there while you're doing it. And you've said yes to this item as part of today's clinical encounter, which means we're not going to have time to talk about the other things on the list today. So it's now about how do we have those difficult conversations with patients? How do we defer this till next time? Because everything you say yes to has a later consequence. So when we're saying yes to more than, and this is not a one problem per visit solution, you're the boss of your encounter. You get to say yes to as many things as you want, knowing that each one is going to take time evaluating it and doing your work in the room, and then the documentation as well. All of the minutes and seconds matter. So if you don't like running late, we need to be curious about what's happening within your day. What time does your first patient start? And what time are they ready for you in the room? What time do you arrive at the clinic? All of this matters. How do we start and end our consultations? That also has an impact on the minutes and seconds within the encounter. For instance, nice seeing you today versus anything else. That sentence, anything else, is going to cost you, because do they have something else? Always. So how we end a consultation matters. How we say, how are you today versus what are we doing for you today? At the beginning of a consultation, we'll have a time cost of many minutes. So it's just the noticing. Does that mean we don't get to have wonderful relationships with our patients? Of course not. However, they have other people to go to coffee with and chat with. Our job within the consultation is determined by you. You are the boss of your encounters. The number of minutes this encounter is going to take is led by you. And that feels difficult when you're in the service profession. But truly, the way we are doing our work within the day has a consequence for how long this appointment will run for. All right. I'm happy to field questions about that, because I know this one's a big one. There are so many components to a clinical encounter. How often do you pull up a blank requisition form and tick a few boxes? That is a time cost. Even if you had a few of the standard things you use and you added the things in, it's going to save you less clicks in that encounter. What do you leave the room for? Every time you leave the room, you will be interrupted. And so being curious and watching and noticing your day and how you're doing your day is going to be super valuable to you if you are wanting to run on time. All right. The exact plan for inboxes, work lists, and forms. So if we think about your clinical day, you have patient-protected time where you're seeing patients and closing charts. If you come out of the room and you open up your work list and you tick a few things off, it's adding compounding minutes to how many minutes behind you are. And most of the time you open it up, see that 5-pager from the neurologist and go, well, I don't have time for that right now. And you close it again. So now you're doing work twice. Or you open it up and you have no idea how to do that thing. Like, oh, I don't really know. Do I ring patients about that, or do I get them back in? Or so we're looking at it multiple times before we get it out of our inbox. So if we've got patient protected time, see patients, close charts. Then when are we going to do everything else? Because it doesn't stop just because you're in a meeting. It doesn't stop because you're seeing patients. That inbox keeps filling up. What's in there? How do you get rid of it? So when will you do this work? Now, if you are in Alberta and you're being paid, however you're being paid in your pay models, right? Because some of you are in different models than fee-for-service. You're in blended capitation. Have you actually given yourself time to do this other work? Or is it just being left to the end of day, evening, weekend? Being curious about when you will do this work? How long does it take? Right? If you were just to do today's work, what comes in today, not what's left from days before, but just today's work, how long is that going to take you? Some of you will have Connect Care Access now. Well, that's a completely separate silo of information. When will you do that work? And so having an idea of what time of day do I do this? What is the priority? For me, like most of you, if I get a request for medication renewals, which you are the boss, you get to decide if you're doing them and how you're doing them. But if you say, yes, I'm going to do those script renewals, well, if I didn't clear them out first thing in the morning, I had a reminder by lunchtime. That really annoys, right? Because now you've got two things for the same patient, more clicking, same task. So now we've added tasks. How much in your inbox is you saying that CT is due for Harry? You're like, why? What CT is due for Harry? And now you're in that inbox, in that patient chart, trying to figure out what was the CT that's due for Harry. And then eventually you find it on an ultrasound last year. You're like, oh yeah, I've got to redo that aortic aneurysm, but it was found on ultrasound last year, but they wanted a CT this year. That is a time cost, 8 to 10 minutes of digging around in a patient chart. So if you're the one who's going to be messaging yourself to remind you to do that CT, make it easy on yourself, your future self. It could look like when you see that ultrasound, write the CT requisition for next year right now. And then the message to yourself or your team says, CT's due in June, requisition's done. And you're like, yes, that just was a 30-second job instead of an 8 to 10 minute job. So each of the things within our inbox and work list needs to be thought about and done in the fastest way possible. Forms. So we just had a 20-minute visit with the patient. And at the very end, they pull out the form and they're like, oh, can you do this when you have a chance? When is that chance? When are you going to do that work? My brain would say, oh, there's an hour of my life gone. But it wasn't just an hour. It was like an entire weekend of, I don't want to do these forms, but I brought them home with me. So I'll clean the kitchen and I'll say no to the barbecue because I have paperwork. And I'd go to work Monday with them not done. Anyone else? So what is your rule? Do you want them in the room for this type of form? Do you want them not in the room with you? Yesterday afternoon, I had the afternoon to do my AISH forms. I like to do part of it with the patient in the room and finish it off on my own. So I assigned time to do that. But if you're not thinking about it, it gets done when you have time, which is typically personal time, right? So you get to be more curious about when do I do this work and how do I clear it out? And then interruptions. So we are all fatigued when it comes to decision fatigue. Every interruption requires us thinking about, well, how do I answer that? Do I have the answers at my fingertips or do I need to go check in that patient chart, but I'm in the middle of something. So now I've got to stop that and turn to you and tell you what the answer is and go back to this. So think about what type of interruptions you're going to be having in your day. Even just watch them or notice them or write them down in the next few days. And then where could you have intercepted to help reduce the number of interruptions? We had a new nurse start in our practice, and she brought to me in the middle of patient time these 3 written messages on paper. Well, I haven't seen that in years. And I'm like, oh, we didn't orientate her in how do I want to receive that information and when do I want to receive that information? I don't want it on paper. It's going to get lost. I don't want it in the middle of patient time. And in the middle of patient time, as she's doing this, is not the time to tell her and teach her how to do it. But that conversation of just put it in my work list or look at it at 12:30. That's when I'm in there doing that work. Will help calm her down because the patient's now rung 3 or 4 times and she's not sure when I'm going to do the work. So now she's got to come bother me. No, we tell her, hey, doesn't matter if the patient rings 15 times. No problem. Let them know. She does her messages at 12:30. After that, she may have an answer for you. So if we can batch even some of these decisions, we'll start to help you reduce your decision fatigue. All right, but that's a lot to change. Yes, it's your entire clinical day, but it is possible to be starting to have a different experience with you having that reflection, that big step back about how did I design this and set this up for myself? What else would make this easier or better for me? If we took your current experience of medicine, we fast forward you 10 years in the future and nothing about your clinical day changes, what will it have cost you? Mental load, potentially under earning if you're doing work on the weekends or evenings where you're not potentially able to add those time modifiers in. Do we have time for exercise, sleep, rest? Is it sustainable? So it is possible. Just take low-hanging fruit. Look at what is discouraging you right now about your clinical day. See, what could I just shift a little bit? We know that seeing a patient and closing a chart, if you're not doing it in that way, is going to take you time. It's going to add minutes to your day initially. And you're like, this is crazy. She's just loopy. This isn't going to work, because you're doing it in a new way. So why would it be worthwhile to do it this way for you if you wanted to? What would be the upside that would help you get there? And then seek help. Do this with others. Tell them what you're doing so that they can help you. Hey, why are you here chatting? Aren't you supposed to be doing your inbox time? That's when you've set it aside for yourself. All right. That is the end of my part. So I would like, now we've got some time for questions. If you have things that have come up about that that you would like to discuss. Everybody's busy finishing their inboxes.
Dr. Smith, maybe while we're waiting for the first questions to roll in, I'll lead off with one. For folks that are saying, hey, a lot of these ideas sound fantastic, I'd really like to start getting going on it, but it does seem like a lot. Do you have any
Yes.
tips of how people can maybe start implementing some of these ideas?
Yeah. So for instance, if you've got a big referral letter to do for this patient, leave that one referral letter till the end or the next time you're going to do that work. But not every referral will take a lot of digging around in a chart. Not every chart note's going to take you. So if you do the chart note after this patient and there's a patient waiting, that is going to make you do it as fast as possible. If you wait till this evening, it's double the time. So that pressing in to get it done right now feels very uncomfortable if you're not used to letting a patient wait another couple of minutes for you. And you get to close that behind you. And what that's doing is keeping you from filling up that working memory with all the patients you've seen for the day. So if you think about walking into patient number 8 for the day and all the notes behind you are done, your brain is a lot more freed up for the decision-making, that high-level work that has to happen within our consultations. So it just gives us a bit more of that focus and control back when we're closing things behind us rather than adding it to the later cart all day. Breadcrumbs. If you're having a crazy busy day, you just sent a patient to the hospital, you've got next patient's crying, next one's got chest pain, leave yourself breadcrumbs. Do not just commit to, I will not leave myself a blank chart ever again. I will put something in there, even if it's just 3 or 4 points to just jog your memory when you come back to that, so that you're not sitting there Saturday morning or tonight going, I don't even remember why I saw this person. I was just flying through that day. And you have to pick up the phone and say, hey, why did I see you on Tuesday? Can you just jog my memory? Those are things that I've had to do way back, right? Of, I've got like all of these. I don't even remember why I saw that, whatever it was. Just leave yourself breadcrumbs if nothing else. Lindsay.
Sarah, I'm wondering if you can give like a couple more examples about inbox management. So you gave that one about like CT scan, like do that requisition now, or even like.
Yes, absolutely.
A couple more examples.
Really important. So when I was kind of noticing how my workflow was, I realized that when it's time for that CT to come up, what will I do? Well, I will write the requisition and then I will forward that onto the referrals person or the CT person within my clinic. Interesting. So what we did is we stepped back and said, okay, well, how does our EMR work? Can we write the requisition right now? And then, so now the way I do it, I read that CT report. I look for danger. Do I need to ring the patient right now because there's danger? No. Okay. Well, I'm probably going to get them back in for a CT because there's usually a lot of information I have to talk to them about. So even if their belly CT is normal, they still have pain that we need to manage, right? So there's no point in me picking up the phone to call them if I want to have them back in person to do that, because a phone call is going to take time out of my inbox work. So if I'm looking at something that needs a repeat CT, I bring up the CT form, I write the CT and I write CT chest due June 2025 and write the reason in there right now because I'm looking at CT form. And then I put a referral into my system on the EMR that says CT test due in June 2025. And my team know to put that forward dated to themselves for about 3 months ahead of time. Now, when we drop down to half the number of CTs in Alberta there for a while, my team sent it 6 months ahead of time. So nobody missed out on their CT because we knew who was due a CT and when, so they just sent them early. So nothing went wrong about that. So it helps you because the next time you see that the CT's due, instead of a note from you saying, you know, CT's due, you're seeing the CT report. It's already done for you. So that's just one of those things. The next one is if you always look at something and you're like, I don't know what to do with this. Let's go with bone density. It's a pretty common one. You look at bone density and you're like, do I, don't I recommend bisphosphonates? Do I, don't I? Or low sodium, whatever it looks like for you, that's you're like, hang up. Find yourself the document, the flow chart, the educational material you need, and put it somewhere where you can find it each time. So you don't just sit there opening and closing it for weeks. Just look at it and say, okay, for this, I do this. When we're booking a patient, say they need an MRI of something, say to them, when you get that MRI appointment, you immediately call and book an appointment for me a week later, so that when that MRI comes in, you're looking at it, you're looking at the fact that they have an appointment in 5 days. So all you have to do is scan for danger because you're not going to call them about it. You're going to see them in a short amount of time about that. Examples of team members to help with charting. Tell me more, Kerry. What are you thinking? Can you unmute?
I can jump in there real quick. One clinic I worked at, the MOA started the note and it was very brief. She might just say right foot pain after injury 1 week ago or something. But then if I had a crazy day, at least I had that information at the end of the day and I didn't have to go, was it the right foot or the left foot? Because we were very specific to the MOA staff to put right and left. So that's one thing
An
that
example
you
of,
get
yeah.
staff to do to help. They could start the note, just very brief history notes, something like that.
And Kerry, are you using somebody or you're having some thoughts about how you might use them? Okay, so just some pros and cons to it. That could be good unless they give you a list of 10 things, in which case you're going to go in and say, okay, I see you've got a list of 10 things. And then you get to negotiate how that's going to happen. We're going to do this and this because they look important, or which of these do you want to do? And don't give them a number because they might choose headache and back pain. And you know that both of those could be a 20-minute conversation. So it's that they might be helpful and they may not be helpful. You've got the option of a patient writing down why they're there. We do that for walk-in clinic for us. We do walk-in clinic that goes from 1 till 4, and we're going to see about 30 patients in that time. So they've written their one reason because we give them rules for the walk-in clinic. So that kind of ties them to one thing that we can see them for. Of course, we can see them for multiple things if we choose to in the room, but you're going to then keep people waiting. So this is a good opportunity. If you don't like people waiting, having 30 people there at 1 o'clock is pretty confronting. And they're all there waiting from 1 o'clock. Not ideal, but it is availability, it's access. And so they're going to be waiting 3 hours, whether you like it or not. That's a good way to keep you moving. And my notes are done after every patient because I do them in the room at that time, right? So the way I do my consultations and the way I do my charting during walk-in clinic is different than when I'm doing it in my regular clinic. And so it's that adaptation. When you're working in the emergency department, you've got notes started by the nurses there, of course, because they're doing the triage for you. How do you do charting after every patient in an emergency situation? It's keeping it up to date to where you are right now. So you see them and you're taking the history, doing the exam, ordering the first few tests, write that down. So you're at that point. So when you go back in next time, you're putting it together and putting in your reasoning, deciding on your diagnosis, that then gets put in there. So that's how we adapt it for different scenarios. If that's helpful. All right, when I'm doing my Connect Care work list, I have two screens. I have my EMR and my Connect Care. So I can see, did this come across to my EMR or didn't it? As a helpful way to not have to send things across from Connect Care to my EMR if it's already there. So just ways to help you be faster about that inbox. But being curious about when you do that work is going to be important. Okay, when we do walk-in, we sometimes do referrals for unattached walk-in patients. I continually get follow-up letters from here on end. How do I manage? Yeah, so it's that helping your patient at the beginning know how will they interact with the clinic after you see them. So you're going to do this referral. It's going to come back to you. So then you may message your staff to say, okay, the referral letter's back. They need to book an appointment or come back to walk-in to get that discussion about this letter. So it's that decision ahead of time. How will you talk to your patient about that referral and what's going to happen once it's done? But you're the one still seeing the letter, and then you might have to call them to tell them, you know, we need to change that med up, or please come back to walk in and tell your staff that. Yeah, perfect. Got a couple more minutes if you've got questions. Otherwise, we'll let the next speaker. Hopefully that was helpful to you about things like referral letters. So if somebody needs a referral done, you may need to get them back to do that referral, right? Oh, and while I'm here, I want a referral to the urologist and the ortho and you're like, okay, great. Let's get you back in so we can do that work. And then even, how have I set up my appointments? When will I be able to get them back if I want them back? Even that is an important part of our day, is that access. Where have we put in those spots for ourselves, or do we keep double booking people? And so we've used up that inbox time. Lots of small changes add up. Yes, absolutely. Little, to start small. Just notice to start with today, just how many interruptions. That could be a place to start. And how do I leave myself even breadcrumbs if I'm having a disaster? All right, I'm going to be done there, Michelle, and let our next speaker have a turn.
Awesome. Thank you so much, Dr. Smith. With that, we will turn it over to Dr. Wayman so we can talk a little bit about how AI can help us in our practices.
For those who haven't met Dr. Wayman, he's a family doctor and rural generalist in Castor, with a special interest in sports medicine, and I think also definitely an interest in technology. And he is our AMA lead for Alberta Surgical Initiative. So thank you for coming, Tim.
Thanks, Michelle. So just to give a little bit of background there, I'm a sort of UK trained family medicine and sports medicine physician who came to Alberta about 14 years ago. I've been around a fair bit, and just listening to the previous presenter about, you know, the day-to-day demands on our time, whether it's patients or admin tasks. You know, I've sort of remember the days where we had the old Lloyd George envelopes in the UK, which was literally like a 6x4 gusseted brown cardboard envelope that we used to put cardboard what's the word I'm looking for, postcards in, that we'd handwritten a summary of our encounter with a patient. And then obviously computers came onto the scene, and I'm still working and trying to make my day more efficient, get better value out of my time, but also trying to coach patients how to get better value out of me. So artificial intelligence, I'm sure all of you have heard of it. Lot of publicity at the moment, lots of high profile individuals talking about it, investing lots of money in it, talking about the end of humanity, the singularity, the T-100s coming from the future to come and kill us all, and robots and everything taking over the world. I don't share that view. I think throughout the history of humanity, we've always leveraged technology to be something that augments human activity. And we may possibly get to a point in time as artificial intelligence becomes more sophisticated where that dynamic changes somewhat. But I think at least initially, it's going to be humans using AI to do more with less and to be more efficient. So the way I like to look at AI is just to change the initials around, and it's essentially intelligent automation. Next slide, please. So what AI does is, machine learning, neural networks, large language models, they're all based on the human brain. So we have 100 billion neurons, 1 trillion connections, and artificial intelligence systems are basically trying to multiply the number of connections, process data more effectively in greater volume, in reducing time. So in that sort of spirit, I basically asked ChatGPT 3.5, which is a free app that you can download from the App Store onto your phone, in what way it would solve the admin burden crisis for family doctors in Alberta. And it came up with a list of 8 areas. So next slide, please. Next slide. So appointment scheduling. So many of the things that we're going to talk about, potentially people already use. So we've already talked about coaching patients to get better value out of their interaction with their family doctors. So trying to get patients to ask themselves questions, present their problem in a more time effective way. Allowing patients to book their own appointments online, allowing patients to dictate the length of their appointment if they have multiple problems and they think that they're going to take more than 10 or 15 minutes, allowing them to book maybe multiples of appointments at the same time. There are lots of studies out there that show that's a time-effective way and an efficient way, not only from the patient's time point of view, but from the clinician's time point of view as well. And that the concerns about patients maybe being unrealistic or overly demanding, the studies don't bear that out. Patients, I think, on the whole, are respectful of the doctor's time and they don't want to waste our time necessarily. There are EMRs that allow patients to fill in forms which summarize the reasons why the patients are maybe coming to see the doctor in the first place. Some of those EMRs will actually take some of that text out of the patient's form that they completed prior to their appointment and populate it into your history, so that you've already got a history there that the patient has provided for you. Automated text messages, sending patients a reminder that they've got an appointment within 48 hours. Are they coming? Are they not? They can cancel, the computer can monitor that, it can flag up a list that your reception staff think, and then look, well, an appointment's become available on such and such a day. I know that Mrs. Bloggs is waiting to see Dr. Wayman, we can put her into that slot. So just maximizing the efficiency of the system. It does reduce no-shows and reduces wait times. Next slide, please. Telemedicine, we're all experiencing that far more in the last 4 years than maybe we ever did up to that point in time. And I think that's partly to do with patient demand and partly to do with necessity in terms of providing access to medical care for patients who, through the pandemic, weren't necessarily able to come in for a face-to-face consultation. There's massive investment going into telemedicine from some very big organizations. I'm sure that we've all had patients who've had consultations with doctors either on Virtual MD, which is run and provided by Alberta Health Services, or Teladoc, or TELUS, or Rocket Doctor, or Maple. There are all sorts of private providers that are providing access for patients, which patients like. There's high acceptability. It doesn't cost the patient anything now because most of the organizations have contracts with the Alberta Health Insurance Plan. Patients like it. It's a natural evolution of how medical care is delivered. People have been talking about it for a long time. It probably just reflects the way that the system is organized and how we're paid, that it hasn't advanced as quickly up to or the onset of the pandemic as maybe it should or could have done. Teladoc have avatars that ring patients up on a scheduled basis to check in with them after they've had coronary artery bypass surgery, and they schedule a number of follow-up appointments. It's an AI chatbot with the one I saw was an attractive young woman talking to a man after he'd had his coronary artery bypass grafting 6 weeks previously. They have over 1,000 consultations that they've studied. The acceptability from a patient's point of view is very, very high. Next slide, please. Diagnostic support. If we think about what we do in formulating a diagnosis, it's really retrieval and processing of data. The capacity to do that is, up until sometime in history, has been sort of retained within, I don't know, however many doctors there are on the planet. Let's say 2 million doctors' brains. With the advance in computing power, speed, volume, all of that information can be stored digitally. Patients can access it. If you look at categories of internet searches for Americans, health questions are second on the list in terms of accessing Google and accessing in the internet. Patients are used to it. I think what we'll find is that we will have AI augmented patients in the future, so they will be coming to see us already having done research, which will be at a higher level than they currently are able to do. The internet basically improved information for patients, but didn't necessarily give them the literacy to understand the information that they were retrieving. AI is going to increase intelligence. It's going to increase literacy for the patients. They're going to be able to sometimes make their own diagnosis and get treatments offline that they don't even necessarily need to come and see the doctor about in the first place. Those that do come to see the doctor, we have to anticipate that they're going to come in a much more prepared state. We already see it in practice. We have patients who have maybe unusual conditions, rare conditions, and they already do research and come and educate the doctors about their own condition. We have communities of patients like me, who communicate with one another and help to manage their chronic diseases independent of doctors. So I use ChatGPT-4. You can literally ask it questions like, what would be the next recommended treatment for a 64-year-old diabetic patient type 2 who's already on maximum doses of metformin, doesn't want to take insulin, has a cardiovascular risk, BMI, etc., etc. Put all that in, and ChatGPT-4 in less than 10 seconds will tell you what to do with the patient. You can ask ChatGPT-4 to show you their working. So where did they get the information from? Ask it to quote references what data sources did they reference in making that recommendation to you. So it helps with our clinical decision making. Next slide, please. So I think we've talked about that. We've talked about increased connectedness with our patients, becoming more accessible in the digital world. Patients can email doctors. Some of us can claim for email encounters with patients. They published a study recently where they took a series of questions posed by patients to their doctors, and they split them into two groups. One group were answered by clinicians, and another group was answered by ChatGPT-4. They then took the answers and they submitted them to a panel of clinicians and asked them to grade them in terms of clinical accuracy and empathy. The panel of doctors were 4 times more likely to take the ChatGPT answer to a clinical question in terms of clinical accuracy and clinical appropriateness. And they were 9 times more likely to suggest the response from the AI bot on the basis of demonstrating empathy, although that obviously in the written word and not necessarily in a face-to-face environment. So, you know, computers, AI, they're at a very high level of sophistication. I'm sure we're all aware that they're able to pass the LSATs and the MSATs. They're clinically as good at decision making and clinical reasoning as your average doctor, and in many instances they're a lot more accurate than your average doctors. Next slide, please. Billing and claims processing, again, just automating things that we do repeatedly, taking the responsibility away from the doctor. The next slide, please. Chatbots and virtual assistants. So there are already things in existence where, to talk about Dr. Smith's example of having a patient that needs a CT scan in 12 months' time, it's possible now to have a conversation with your AI assistant. Mr. Jones needs a CT scan of his abdominal aorta on the basis of an ultrasound report from 12 months ago for surveillance of increase in size. Please produce a CT request form for my signature, and they can do that. We have technology that will record an interaction with a patient. So charting, I mean, really, it's just a record of an encounter with a patient. You know, often there isn't really a great deal of useful information in there. We're fulfilling a requirement from a medical legal point of view. We're covering our backs or asses in case anything happens, which in 99.9% of cases probably will never happen for somebody with an earache or a sore throat. But we have this moral obligation or professional obligation that we feel we need to make a recording of something that potentially will never happen again in history, and will never be revisited by anybody for any purpose whatsoever. So automating that obviously takes that pressure and workload away. There are software programs that are available now where you consent the patient and tell them that the interaction with the doctor is going to be recorded, and it will transmit it into text into your EMR and summarize your encounter with a patient. Nuance and Dragon already have that available. It costs about $600 for setup, and then you pay a monthly fee, which I think is of the order of about $90 to $100 for unlimited access to that. And up to present, patients, 98% of patients consent to that level of interaction with their doctors. Some medical fields use video recording. Video recording of operations has been done for decades. Video recording of medical legal experts examining patients and recording their examination findings in a video format. It's just information. Anything that doesn't require the doctor touching the patient can be recorded and converted into text into your EMR. Even in an examination information, you know, you can instruct your software package that I'm examining Mr. Jones's abdomen, and I've found that there's a potential mass in the right upper quadrant. The characteristics are 10 to 15 centimeters. So almost giving a commentary as you're going through your examination routine. The software will convert that into text and put it into your EMR. you can instruct it that I'm going to need to do a referral for an ultrasound on this patient. Please populate an ultrasound request form with the relevant details from the encounter. It's going to represent a massive time saving from doctors and patients' point of view. Next slide, please. Prescription management. Yeah, it's archaic, isn't it? You know, we have patients who manage their chronic diseases. Sometimes they refer to the doctor. You know, I'm sure we all have patients who increasingly monitor their own blood pressure, monitor their own blood glucose levels with continuous monitors. They put it into various areas on the internet that can be granted proxy access, whether it's their doctor or their carer, to know what their blood sugar is running at or their blood pressure is running at. You know, biosensors are becoming more and more prevalent. We can monitor oxygen concentrations, take an ECG from our smartphones or our smartwatches and send it anywhere that we choose to send it. And yet we expect patients to come into the office and have a face-to-face consultation, sometimes just to get a piece of paper that enables them to go and get drugs from a pharmacist that they know that they need and that they've been taking for the last 5 to 7 years without any changes. So we can automate that for sure. Next slide, please. So we've already talked about automating data entry. You know, we know that streamlining management of electronic records. I would go so far to say that electronic health records up to this point in time have not necessarily delivered on the promise that we were maybe hoping for in terms of increasing or improving patient care. There's not a lot of hard data that it changes clinical outcomes when it comes to handling patients. There's a lot of data that says that the actual face-to-face time that a doctor spends with a patient has actually gone down because they are obligated to enter information into the computer. I think that's going to change. I think, you know, the responsibility and the task of entering information into a computer is going to change. It will save us time. It will become more time efficient so that we can be more present with our patients and spend more time interacting with them, having you know, tools at our disposal that automate everything else, or automate a lot of the responsibilities that we have in recording our interactions with patients. Next slide, please. Yeah. So I'm no expert on technology, although Michelle sort of introduced me as a technophile. I'm certainly probably an early adopter, maybe more than I should be. But you know, technology, I'm not completely at its mercy, shall we say. I try to use it to save myself time to provide better services for patients. There's lots of references out there. There's, you know, I've basically just put a list here of some books that people might choose to read if they haven't already done so, which would give them an understanding of how AI is going to impact on medicine. AI is what they call a general purpose technology. It can be implemented across a wide range of different disciplines, different industries. It's going to have an impact for sure. I would suggest that we embrace it and use it to improve our life experience as doctors, but also to improve the care that we deliver to our patients. So I'll stop there because we're at 8:30. I've overrun again, Michelle. I apologize.
There's so much interesting stuff. So big thank you, Tim, to you and to Sarah. I think there's a lot. I think people's heads are probably pretty full for a Wednesday morning. So just really quickly to wrap up, just a reminder that any of this work that, you know, incorporating AI or working on your charting strategies, these will qualify as a QI PIP if you haven't done that yet. A couple of PIP opportunities. We mentioned this last time. This one is related to care planning with some remuneration attached. We'll send this out in the summary email if you're interested in learning more about how to participate in this. And then there's another one related to shared decision making. This one is a very short one, a 3 to 5 minute survey, but with the information, they'll be able to create something that, again, you could use for a PIP opportunity. So again, this will be in the summary email. And our next sessions will be, the morning session will be June 5th and the evening option will be June 11th. We'll be continuing on in our theme of working smarter, not harder. And it will be going deeper into the scribe aspect of the AI that Tim mentioned. So we are planning to have kind of a live demo of what it would actually look like when you have that scribe function working in your EMR. So, and we will record that one too. If you can't make it, we'll send the recording out. But do watch for the summary email. That's where the video is and all of the extra information. And that's it for our session today. Thank you everyone for coming, and we'll see you in June.